So race, racism, and healthcare, it's really a hard act to follow the patient group, but Tamara really, how many times was that word used just in the past 30 minutes, right? So, how did a white boy like me get to a place like this where I would even have a conversation about race and racism? All right, so that's me. That is 1984. I am rocking the Farrah Fawcett hair, right? I am focused when I open. Yes, that's me. That is me. That is my first year of medical school. I am focused on dissecting that cadaver. And I came home from work about 6 weeks ago, and I turned on the television, putting my stuff away, and Lester Holt from the NBC Nightly News was on, talking about Eastern Virginia Medical School. I'm like, oh, that's where I went to med school. What are we famous for now? It used to be first test tube baby in America. So I'm like, oh my goodness. Now we're famous for, that's the governor of Virginia.
Oh, yeah.
And I didn't know I even had this yearbook. That is where I went to medical school.
Wow.
That is where I learned to be a physician.
Wow.
This is the governor of Virginia who is in blackface. That is my medical school yearbook. I didn't know I had it. My partner knew where it was and found it. And yes, I am certain I looked through that yearbook hundreds of times and never noticed. I have it at work. You can't even get to page 10. There's somebody in blackface. There's someone molesting the Rasussa Annie doll. There's a racially offensive coffee mug that the pharmacology professor is holding, and on and on and on. And this is the culture where I learned to be a physician. And if I think that doesn't affect how I view patients of color, right? And I would say that the culture of medical education is no different. It's just not acceptable to dress like that and put that picture in your yearbook. And I look at the yearbook now and I want to vomit. But at the time, it's like fish in the water. It's fish in the water. I never noticed it because I'm not supposed to notice it. And it's only been, you'll hear a little bit about my journey, it's only been the last few years that I'm starting to see the water. And I will continue to make mistakes as I don't see the water. And I appreciate everyone's patience with me as I try to still see the water. And I love that quote from Ijeoma. I'm not supposed to see it. Right? So how did I get here? I've had the honor of taking care of sickle cell disease, 3 of whom are up here. It's really amazing, right? I've been at Children's for 26 years. And it wasn't until 2009, 10 years ago, I was at a conference in North Minneapolis, and there was a 90-minute session. I had some time to kill. One of my colleagues said, well, you should go hear Dr. Heather Hackman speak. She's now my colleague in racism and whiteness training for healthcare providers. I said, sure, I'll go. I got 90 minutes to kill. And she was speaking on white privilege. And I sat in there at age 48, everybody do the math, right? I was embarrassed because I'd never had to think about this issue because I am a white man in the United States of America. Never had to think about this issue. And within healthcare, I'm a physician. Because a lot about what we're going to talk about is about power, right? A lot of this is about power. So I started thinking about, as this has been said many times, sickle cell disease is a global disorder. It affects people of all races across the continent. But in the United States, virtually all the patients are black. And that is a direct result of the Atlantic slave trade that started 400 years ago, 5 miles from where I grew up in Virginia. And I never learned that fact in my 8 years of required Virginia history. This is something that I've learned more recently. So then I started thinking about, as I'm dealing with my own embarrassment, I started thinking about my patients and my families. And at that time, we probably had 200 kids, we now have 300. And all these families have a different story. All of your families have a different story. And all of my sickle cell families had a different story, but they all had one thing in common. Not a single one of them was white. And I started thinking about me and the system and the team. And at that point, pre-Ray, every single one of us was white. And I thought, could that matter? Could that fact alone affect the quality of care that our patients receive? Or at least the perception of that care? So we asked the question. It matters. It matters a lot. And this was published in 2013 in our flagship journal for pediatric hematology oncology. And it took months to get it published because the editors did not want to have this conversation. These are hard conversations. But it did make it through, and it was the highlighted article of that month's issue. And I so love what Alexis Thompson said. Once the Sickle Cell Clinic of Lurie Children's was the past president of the American Society of Hematology. She's a fierce black woman. I love her. And basically, what she said was, can we stop admiring the problem? What are you going to do about it? What are you going to do about it? And depending upon the audience, sometimes we need to spend a whole hour, 2 hours, all day on the it. Right? We're going to talk a little bit about what the it is. Right? White people live longer than black people in this country. You can add any person of color. Right? And I fall into a black-white dichotomy because I'm white and my patients are black. But let's be clear, right? This is not just about black and white, and this is not a surprise to anybody. It's never a surprise to my colleagues. But then the question is why? How I have tried to reconcile it, and I catch myself still doing it. Well, it must be about genetics, or it's about these social determinants of health, which are important. We're going to talk about that: socioeconomic status, health literacy, access, education, but also racism, unconscious bias, and stereotyping. So I like to use this parable. Some of you may have heard it. I don't know how to get my arrow to work, but trust me, there's someone taking a walk along the Mississippi River. Right there. Say that's you, walking along the Mississippi River. It's a beautiful fall day, and a baby floats down the river. You jump in and save the baby. You might take a minute to take your phone out of your pocket, but you jump in and save the baby. All right, 2 babies. I'm going to jump in and save those 2 babies. Now there's 10. There's 100. There's 1,000 babies floating down the river. You were calling 911, flagging down those cars up of I-94. You were spending all of your resources, your time, your energy, your education, your skills, your power, your money to develop a system to save the babies. And you're so caught up in doing that, you don't have time to figure out, well, why are the babies floating down the river in the first place? That's how healthcare and medical education function. We bust our butts all day long saving the babies. When I was in med school, residency, fellowship, I learned how to save the babies. Don't get me wrong, you want your healthcare providers to know how to take care of a heart attack or your diabetes, but we spend, and we as a country, spend more money than any other country on saving the babies. We don't spend resources like other countries do. Well, how do we prevent the babies from floating down the river in the first place? So it's this upstream structure that I want us to talk about. So back to the why. Oh, so it must be about genetics, right? Well, Human Genome Project finished in the 1990s, mapped out the entire human genome. Over 60 families' genes were analyzed. There was not a single family of African descent. Yeah, that's the reaction you should have, because the human race started on the part of the earth that we call Africa. Yes. And then, again, fish in the water. Finally, someone pointed that out, like, oh, yeah. So then Howard University, HBCU, got a late invite to that party. But initially, the entire... So, anyway, many, many conclusions to the Human Genome Project. There is no genetic basis for race. Right? There's a greater likelihood that I will have differences between me and a fellow, presumably white man, than me and a person of color. Race was made up. Race was made up starting in the mid-17th century, around 1651, in my home state of Virginia. And I did not learn that in my 8 years of required Virginia history. Right? Race was socially constructed to support systems of power. Okay, so if it's not about that, then it must be about these social determinants of health. And these are important. And when you correct for them, you can do a PubMed search. I picked 2003 because that's when the Institute of Medicine published Unequal Treatment to show that there are racial disparities and that racism and provider bias played a role, almost 10,000 articles, over 10 articles a week. And in the vast majority of those, when you correct for socioeconomic status, do you speak English, did you have insurance, all those kind of things, race by itself comes out as a factor. I'm going to share one of those 9,000 articles. I want you to see that it's 2015, not 1965, not 1865, now. And this is ALL, acute lymphoblastic leukemia. It's the most common cancer we take care of in kids. 5,000 American kids every year will get leukemia. It's the most common thing we take care of in clinic. It's good old ALL. This is 9,000 kids in California, and they corrected for socioeconomic disparities. Who lived the longest? And you can see the Kaplan-Meier. Who lived the longest? White kids, Asian kids, Latino kids, and then black kids. And had there been enough patients, the bottom line would be Native Americans. And that is the Kaplan-Meier survival plot for pick your diagnosis in this country, really. There was not one word in the discussion about me, or about us, or the system, or racism, or bias, or, so I wrote a letter to the editor, as I am wont to do, just pointing out that we as an organization should at least consider how systems of racism affect our decision-making, and how the stress of discrimination can have effects on the human body, and blah, blah, blah. It was beautifully written, and I got a one-sentence response. Dr. Nelson, your letter, though heartfelt and true, is unrelated to the article in question. So that fish in the water. Complete, utter lack of awareness of how these two things could be related. So I started to fire off the email that, the email that you should have your trusted friend read, and it was not good, and there were F-bombs, and I called him an a-hole, and I didn't send it, thankfully. But I took a breath, right? Did a 2-week break. But what I did was I started talking to my colleagues in the clinic. Did you see that article? Yeah. And their reaction would have been my reaction. Yeah, of course those are the results. And not questioning it any further. I said, yeah, well, this is the letter I wrote. They're like, oh, huh. This is the response I got from the editor. 15 of my 16 partners wrote a 3-page letter to the editorial board of pediatric lung cancer. And the letter was published the next day. And I tell that story just that this is hopeful work. This is hopeful work. So what's happening nationally? So the National Healthcare Disparities Report comes out every year. In Minnesota, we are always in the top quartile for outcomes. Right? We're always in the top. But the subtext is, unfortunately, is if you're a white Minnesotan. And we're also, this is the first year since 2003 that we are not in the bottom quartile for people of color. So we're in the third. So we've made some improvement, right? But also every year in the National Healthcare Disparities Report, when you correct for, did the patient have insurance? What was their income? Did they speak English? All of those things. Race by itself is associated with poor outcomes. So that's what happens nationally. So how are we doing in Minnesota? So the social determinants of health. The World Health Organization ranks these. Number 1 is peace. Number 2 is shelter. Number 3 is education. Number 4 is food. Number 5 is income. And I want to share a story. I was giving a talk to some social workers in Ramsey County, which is the county within which St. Paul is in. And I got to that part and said the stupid, unaware white man thing. Good thing we're not at war. Meaning, good thing we don't live in Afghanistan. And a little hand went up in the back. And it was a Latina social worker who said, with all due respect, you might not be, but as a woman of color in the United States, it can be a battle every day. So I so appreciated that, and I want to take feedback, and it's one of those fish in the water moments. I have the fish in the water moments all the time. All right, shelter. In the 2010 census, Minnesota was 5.2% black, 48% of homeless people in Minnesota are black. Right. Education. We rank number 48, number 48, 50, 49, and 50 for finishing high school for Black, Latino, and Native American Minnesotans. Median household income is lower for all families of color, including Asian families, compared to white families in Minnesota. Incarceration rates are 10 times that for Black Minnesotans, 13 times that for Native American Minnesotans. This is probably not a surprise to anybody. And I would often stop right there And then sometimes I still catch myself doing it because of 58 years of racial narratives, stopping right there. There must be something wrong with Black Minnesotans that they're homeless. There must be something wrong with Latino Minnesotans that they don't finish high school. There must be something wrong with Native American Minnesotans that they end up in prison. Right? Essentializing marginalized groups as somehow being innately inferior without looking one step upstream. Right? What is it about our systems and structures that affect those social determinants, that affect behaviors? Right? We make the choices that we have. I mean, I've caught myself thinking, well, why don't you just move to a better neighborhood where it's safer, you can exercise and there's good food choices, with no understanding of how our neighborhoods got to the way they are, right? Which affect biology, saving the babies. So let's stick with the saving the babies. We're not saving the babies. Infant mortality for Black and Native babies is 2.1 to 2.4 times that compared to white babies in Minnesota. And this is old data. This is from 2009. Things were getting better. But this is the most recent data from the CDC. You can see this is the infant mortality rate per 1,000 live births. Oh, sorry. It's very sensitive. And Minnesota's good, right? So we're 4.09. We're better than average. The US rate is 4.95. You know, Garrison Keillor says we're all above average. So we're doing great for white babies. For Black babies, it's now 2.6 times. It's actually gotten worse over the last 10 years. And Beverly and I had some conversations last night about this, and I'll say, thank God for Wisconsin. Wisconsin has the highest infant mortality rate for Black babies in the United States. It's 3 times that compared to white babies. Let's put it in some context. The infant mortality rate for Black babies in the state of Wisconsin is the same as the infant mortality rate in Syria. Mm-hmm. The infant mortality rate for Black babies in the state of Wisconsin now is the same as the infant mortality rate in Syria. Now, the top 3 sort of vie for number 1, but what is the most racially segregated city in the United States of America? Milwaukee, Wisconsin. So these 2 facts are not unrelated. There's a great book by David Ansel called The Death Gap. He drives along Ogden Avenue from North Lawndale to the Gold Coast of Chicago, and let's see how life expectancy changes. You can do that along I-94. Just my drive from uptown to here. Right? You can do that experiment, it is an experience, in just about any metropolitan area in the United States. What he says in the book is really telling. Where you live determines when you die. Where you live determines when you die. And so much determines where we live, right? Systems and structures affect that. All right, well, this can't be happening in pediatrics. Come on, now. We wear bow ties, and we crawl on the floor, and we play with the kids, and it's family-centered, and it's awesome. This cannot be happening in pediatrics. No way. All right, I'm going to show you some studies from a large inner-city children's hospital. I want you to notice a few things as we go through the year. 2012, not 1962, not 1862. Now, here's a study looking at kids with a broken bone, long bone fracture. How long did it take families to show up to the emergency room? And you can see for families of color, 2 to 10 hours longer. Some of that is, how am I going to get there? I can't leave work, I'm going to be fired. How am I going to pay for it? Or in this particular clinical situation, how am I going to be treated once I get there? I.e. child protection, right? So same inner city children's hospital, looking at a big cohort, 77,000 kids over a year. How long did patients wait in the waiting room? And you match for triage, right? So somebody who's got a gunshot wound should be seen before somebody with a sore throat, right? So this is matching. We could have a long conversation about who assigned the triage score, but that's another story. And patients of color waited longer, and we love our p-values, statistically significant. So same cohort of 77,000 patients, looking at this phenomenon of leaving without completed evaluation and therapy. Oops. So like, when did families get frustrated and leave? They got tired of waiting in the waiting room, they got tired of waiting for the nurse, they got tired of waiting for me, they threw in the towel. So you can see that families of color, 2 to 3.5 times the rate of the reference group. What is always the reference group? White families. What you can't see in this slide, but in the meat of the article, was the families that were a close second to the white families were families that didn't speak English because they had an interpreter / advocate / navigator, someone to help them maneuver this unruly system that I can't figure out half the time. And I've been advocating for years for health equity advocates, patient advocates, but we got Ray through a HRSA grant and now through some philanthropic monies to advocate for our families. And I think historically in this country, if you believe the myth of meritocracy, that if you speak English, buck up. Pull yourself up by your bootstraps. Like, why would you need any special attention or advocacy? So I think that's part of the issue. So then back to the kids who broke a bone. And you can think about this now within the opioid crisis, and you think about our sickle cell patients within the opioid crisis. Who went home with a prescription with pain medicines that had opioids in it? Much less likely if you were a family of color. So same inner city children's hospital, but a larger cohort over 3 years, over 2,000 patients with a long bone fracture. There were more boys than girls. That's a shocker, right? I have 3 kids. 1 boy, 2 girls. I've been to children's ER 5 times. Guess what? Every single time for my son. And the last time we were there, he got stitches. It was up to a grand total of 58 stitches. To which he said to the nurses we were leaving, so far, let me check. Nope, we're good. We're still at, I'll have to go take him to the kitchen. So then this cohort, they looked at time to getting pain medication. If you were a black kid in this ER, you waited 19 minutes longer for pain medication, and you were less likely to get something IV. And as upsetting as that is, the conclusions. Well, there must be something they're not telling us, or variable tolerance to pain. Whoa, that's the year 1851 when Dr. Samuel Cartwright said that the darker your skin color, the less you feel pain, so go ahead and beat your slaves, it's fine. Like, whoa! And if we think that that's over, survey of medical students from the University of Virginia, 2016, the majority still believe that, right? But again, not one word about me or us or the system playing a role. And then this was 2011, but updated from this same institution to 2018, another 1,300 kids. They made some changes to their electronic medical record so that everybody has morphine ordered, but the black kids still wait 15 minutes longer because we can't automate away bias. So as upsetting as that is, so every single one of those studies took patients longer to show up to the ER. They waited longer. They got frustrated and left. They waited longer for their pain medication, and they didn't go home with a prescription. Every single one of those studies is where I work. So if you were expecting to see a picture of the Children's Hospital in Birmingham, Alabama, or Durham, North Carolina, where I did my fellowship, it's here. And I always want to take a moment to give kudos to my ED colleagues for gathering that data, getting those results, having the guts to publish it, and not just admire the problem, but doing something about it. They have a Sanford Health grant, and we have health equity coaches. They're doing something about it. And it's not just happening in the ER or in sickle cell clinic. It's happening all over our hospital, at every single hospital in the United States. This is what's happening. So that's the it, right? The elephant sometimes is that race by itself matters. All right, so back to this system, this upstream, this structure, barriers to equity, there are many of them. So whiteness, and that's not just about what we look like as a healthcare team, and only 4% of licensed physicians in this country are black. Only 11% of licensed physicians in this country are black, brown, or native, right? Serving 30 to 40% of the population. The other thing about whiteness, and it came up with clinical trials, right? Many clinical trials, people of color are underrepresented in clinical trials. So we have white researchers doing research with white patients and getting outcomes and evidence-based guidelines that, one size does not fit all. And then just what are normal values, right? I spend every day in clinic looking up the normal values changed by age. What's the normal MCD and hemoglobin for? That's 239 kids from Helsinki, Finland. Pediatricians live and die by the growth chart. If you're growing, things are good. Well, the growth chart is full-term white formula-fed babies in southeastern Ohio, right? Get the point. It's just things are getting a little bit better, but you'll even see in articles, and I still say it I still say it myself and I try not to, but when there's studies done around race, you'll see the results for white and then non-white. Well, I wouldn't call you a non-man, but words matter. Like that white is normal and everybody else isn't. So the social determinants of health we talked about. I think I did something and turned this off. I don't know what I did.
There's one on the chair.
Yeah, maybe that one will work. Test. Oh, here we go. You can hear me now?
Yes.
So we talked about social determinants of health. System affects that. Racism does two things. It has physiologic effects on the human body for people of color. Now, this is about discrimination. You could put in other marginalized groups. I'm in a wheelchair. I'm deaf. I'm gay. I'm transgender. I'm obese. I'm whatever. There's a lot of intersectionality here, right? But being discriminated against has physiologic effect on the human body. Stress. And I think it was Anissa who talked about, you have like the cars running at you, you have this thing, and then it settles down. But it doesn't settle down, right? When she was describing that, I was thinking about racism. That's what I was thinking about, right? That cortisol levels are high. We know that black babies are smaller than white babies across all gestational ages. There's a baby born to a black woman who's got her PhD from Cornell is going to be smaller than a white baby born to a 19-year-old high school dropout. And there's a great series called Unnatural Causes that PBS did. Episode number 2 is called When the Bow Breaks. 28 minutes is awesome. Looking into that, and there was a study done. They looked at white babies, black babies born to moms who were born in West Africa, and black babies born to moms who were multi-generational African Americans. And the black babies born to the African-born moms were the same size as the white babies. Right? So there's stress, and in this particular situation, the stress of discrimination affecting cortisol, blood pressure goes up, placental blood flow drops. What was interesting about that study, if you were a black baby that was normal size, because your mom was born in Africa, and you were a girl baby, when you have a baby, it's going to be smaller. That assumes you stay in our highly racialized United States. It's called the weathering effect. So that's one thing racism does. But it also, what we're going to end with, it affects me. It affects how I think. Racial narratives affect my biases. Patients, poor health literacy, fear and mistrust. Yvonne talked a lot about fear and mistrust of the healthcare system, spent a lot of time on Tuskegee, but our patients aren't thinking about Tuskegee. Right? There's a great book called Medical Apartheid by Harriet Washington, who chronicles experimentation on black Americans from the Revolutionary War to now, and there are like 26 pages on Tuskegee in this 400-page book. I mean, there's stuff that's continuing to happen that affects our trust. Community and advocacy, there was a lot of discussion about, we have 2 FDA-approved drugs to treat sickle cell disease. Sickle cell's been around for hundreds of years. First case report was 1910, the November issue of the Archives of Internal Medicine by James Herrick, right? Describes what we today would call acute chest syndrome, but it was a young man who was going to dental school in Chicago from the island of Grenada. That's the first case report, so 109 years. Let's think about HIV. It was first described in 1981. We've known about HIV for 38 years. There are 41 FDA-approved drugs to treat HIV. Cystic fibrosis, 5 new drugs just in the last 4 years. We already talked about the budget difference of the CF Foundation, but also your tax dollars. 11 times more your tax dollars support NIH-funded research for CF compared to sickle cell disease.
And the numbers aren't that much different with cystic fibrosis, right? 1 out of, you had it in the earlier session.
Yeah.
With sickle cell in the country is 1 out of 23.
So 1 in 2,400 Americans have sickle cell disease. 1 in 3,500 Americans have CF.
Yeah.
There are 3 times as many Americans with sickle cell disease compared to CF.
Yeah.
But yet 11 times your tax dollars support NIH funding for CF. Right? So the other piece was advocacy. So when HIV hit the scene, gay and lesbian groups like ACT UP and the National Hemophilia Foundation, these are groups with money, power, resources, time, energy, influence. They're beating the doors down. You gotta fix this. Through their legislators, their state health departments, the CDC, the NIH, you gotta fix it. Now, HIV is not fixed, don't get me wrong, but it is no longer a death sentence as it was in the early to mid 80s, right. So that really can speak more to what, how many resources and power the SCBA has, right, compared to other organizations. And finally, it's me. Like, what about me? Implicit bias, stereotyping, and power. So the one med we have is hydroxyurea. We talked about how it's highly underutilized. And there was a consensus meeting at the NIH in 2007. I attended it, and a consensus statement was developed and widely distributed. We got to increase the use of hydroxyurea. And it was great, well done, okay. So then the adult provider network, I don't take care of adults, so Sophie Lanscrontz from Hopkins and Catherine Hassel from Denver, just sent out a survey to adult providers and asked 3 questions. Have you read the statement? Do you agree with it? Do you routinely offer hydroxyurea to your patients? And the providers of color, 100% across the board. Yep, read it, yep, love it, yep. I offer hydroxyurea to 100% of my patients. The white providers, 100% read it, 98% agreed with it, 40% routinely offered hydroxyurea to their patients. And if I'm honest with you, I was one of those people. In 2008, when I was still a fish in the water, I can tell you exactly where I was standing in the clinic when Ms. McDonough came up to me, and I'll change his name, and said, what about hydroxyurea for Mario? I said, he won't do it. I decided he wouldn't do it. I decided he wouldn't pick up his prescription. I decided he wouldn't take his medication every day. I decided he wouldn't come to clinic every month for his blood work. I decided that because of the narratives of what a 17-year-old black boy from North Minneapolis with no social support is. And that is not okay. And I still catch myself doing it. And maybe Mario would not have been able to adhere to the medical plan because of the barriers in his life, but you know what? I should not have been one of them. That was my stereotyping and implicit bias at play, and we all do it. There's conscious bias, explicit bias, and there's implicit unconscious bias. Explicit is, I say, I prefer white patients over black patients. I said it out loud, right to your face, because I think I have some data to support that belief. I would say 99.9% of healthcare providers do not feel that way. We have very low explicit bias. We want good outcomes for all of our patients. But we have implicit bias, which is, how long am I in the room? What's my body language? What's my tone of voice? Am I looking mom in the eye? Am I calling her baby by the name or a pronoun? Right? That, the more I do this, the more I think my patients often aren't really listening to the words that I'm saying, but it's about relationships and developing trust and making a human connection. For that case 10 years ago, I didn't even get in the room. Right? One thing we don't learn about in medical school and beyond is power. I had a lot of power that day to not offer hydroxyurea to that patient. And it saved me a lot of time. I love the Onion, my most trusted news source, right? It's funny because it's true. We all do it. Within a nanosecond, I go into a patient's room. I have a pretty good idea of your age, race, and your gender. And that means something in this country. I might think I have an idea about your job and your socioeconomic status or your spiritual beliefs based on how you're dressed, and that means something in this country. And it saved me a lot of time that day to not offer hydroxyurea to that patient. We all do it. And in healthcare, we are ripe for functioning at an unconscious level because we're busy. All the rooms are full, right? I got all this charting I have to do. And if I can get the answer before I even go in the room, then that's going to save me a lot of time. And the electronic medical record has not helped. This was an editorial in JAMA a few years ago. It's a girl seeing her pediatrician. She's getting her exam done on the table. The sister actually drew this picture. She's sitting there. There's the mom. Where's the pediatrician? Sitting with her back to the family, right? this is about making human connections. The processes that I'm talking about transcend race. It's about making human connections and trust. She's got her back to it. We spend so much of our time on the computer, it takes time away from making human connections. We all stereotype, but they're dangerous. And I love what Chimamanda Adichie, she wrote Purple Hibiscus and Americana was one of her most recent books, which is amazing. You know, these are dangerous. Okay, so that's what it is. So how do I know? I have colleagues say, well, how do I know that I have implicit bias? Well, the easy answer is because you're a human being. We all do it. But there is a way to try to objectively measure. It's called the implicit association test, and you will get these slides. Is anybody familiar with the IAT, implicit association test? It's a way to try, and you can have an argument about the validity. You can read the book The Blind Spot that talks about how they developed the test. It's the best thing we have. But basically, it's a computer test, shows pictures of human faces and words, and you associate them. Rose, thorn, white face, black face. And there's now 30 or so permutations by age, race, gender, obesity, just trying to assess your implicit bias, how the racial narratives that wash over all of us. So I do it every year in January. And I do adult faces, white, black, to sort of mimic the parents of the patients I take care of. And I still moderately prefer white people. And I like to think that I am consciously working against this. It's this idea of the aversive racist. Most physicians are aversive racists. We have very low explicit bias, but we have very high implicit bias. And interestingly, you can read about the IAT, people of color, also the majority prefer white people. This internalized racism, those same narratives of what's normal and what's superior. It's really fascinating. But this is about power. I mentioned it a little bit. I could go into a patient's room and it's a white upper middle class family from Medina. And say both parents are physicians. Say both parents are pediatric hematologists, just like me. I still have more power than they do because their kid is sick and they're scared. So let's layer onto that differences between me and the family around gender identity, sexuality, language, religion, income, smoking, disability. I mean, that power differential can feel overwhelming for the patient and family. I can't change that power differential, but I can become cognizant of it before I go into the room. So this is about power. All right, so I have colleagues say, we all do it. Okay, yeah, I get it. But does it really matter? Why are we spending 45 minutes talking about this? Does it really matter? Does it really affect outcomes? And this article just came out about 6 weeks ago, acknowledging some limitations to the IAT, describing beautifully this aversive racist. We have very low explicit bias, very high implicit bias. And although our decision-making in many of these vignettes and cases was the same, the physician ultimately offered hydroxyurea, but the delay in the process led to mistrust. If there's better trust between the patient and provider, there's a greater likelihood that the patient's going to adhere to the medical plan. And there are 40 articles that look at when there's cultural and racial concordance between patient and provider, there's better outcomes because there's better trust. So 4% of licensed physicians in the United States are black. 0.9% of licensed physicians in Minnesota are black. This is not an option for our patients. So until then, I'm the one that needs to do the work. I'm the one that needs to improve my ability to build trust and make human connections with my patients so that they have better outcomes. We don't have time to show it, but is anyone familiar with this video called Crisis? And again, you'll get the slides that'll have the reference. It's a 7.5-minute video done by the folks at Johns Hopkins, following 3 adult women with sickle cell disease and their experience, things that beautifully this panel described. But there's one poignant moment. This woman talks about how she's in the throes of a pain crisis. She takes time to do her hair, to put on makeup, to dress professionally, so that when she gets to the emergency room, she is taken seriously. And I think about the last time I went to the ER with my son. It was 7 o'clock in the morning on a Saturday. I scooped them up and we went. I hadn't showered, I hadn't shaved, I hadn't brushed my teeth, I probably stunk, I might have had shoes on, I don't know. Because I had zero concern about how I was going to be treated when I got there.
Mhm.
Right? And some of that is because I work there, right? I'm a physician there. And we've done lots of trainings at Children's, and we're hoping to do more and more with the addition of James Burrows. We have a Chief Equity Inclusion Officer now, and I think Children's is starting to make some movement. But one of the Somali dietitians, came up to me after our session, and we had watched the entire video. She said, yeah, I bring my kids to Children's too. And when I bring them, I make sure I wear my children's ID badge.
Yeah.
If it's 2 in the morning, Saturday, because I'm treated better. And that really moved me. I wear my badge everywhere I go. My badge is my white man face. That doesn't make me a bad person. It doesn't mean that I didn't work my ass off in medical school, but I have to acknowledge that I have privileges. Because I just walk around with this. I didn't earn it. I just happen to be born with physical features that are highly valued in the United States over 400 years. Right? So, this is why we don't make movement, I think. Why it's so hard for white people to have this conversation. Right? I start to feel bad.
Mm-hmm.
Right? Well, I didn't cause racism. I didn't own slaves. Well, good, Dad, because you were born in 1936. Sorry. This idea that we didn't cause, or this idea of making it personal. Let's be very clear about racism. Racism is systems and structures, not individual acts. Right? Do not confuse the presence of racism with the presence of bad people. Because once you start to personalize it, the conversation is over. And what an amazing privilege white people have. As I think about all the privileges I have, the biggest one I have is I can choose not to think about this anytime I want to.
Ever.
Right? That gas pedal, I can take my foot off the gas and I can go back to, right? Because this is upsetting and hard. Racism hurts all of us, right? And I can choose not to think about this whenever I want to. And I could add to that sexism as well as a man, right? I can choose not to think about it whenever I want to. The other elephant in the room that's hard for healthcare providers, especially my fellow white colleagues, is that I'm part of the problem, right? That racism has physiological effects on our patients, but also it informs how I make my decision making. So what do we do about it, right? So, I mean, our organization does good things. We can do diversity training and cultural humility training, right? The X should be over competency, not humility. That, I think, was a PC to a Mac. So it's really, there's no way for us to be competent in all the hundreds of cultures. We can be humble, right? And those are great, but neither of those address systems and structures and power and oppression. And until organizations like my own do that, we're never going to see any movement. So what we're starting to do at Children's, and I've partnered with Dr. Heather Hackman, is to do social justice training for healthcare providers. We did our first pilot with the Broadway Family Practice residents in North Minneapolis. We did a follow-up session with them as well, faculty and residents. We're going to start doing some trainings at Children's. This is how we're going to make movement, but that's going to take time. Right? There are a lot of barriers to this. The culture of medicine, fix it. What prescription do I write? What surgery do we do? Move on, next patient. It has taken us over 400 years to get where we are. We're not gonna fix this and having Nelson talk for 45 minutes, right? But there are some things we can start doing right now. What I tell my colleagues, starting at 2:48 p.m., right? Just starting to look at your day with a critical race lens, wherever you are. If you're at work, just look around the room. Right? You're at the airport, in the TSA line, or on the airplane, or you're at the grocery store, or wherever you are. Like, why does the room look the way it does? Right? How is race playing out in OPC? Sometimes the answer is not at all, but that's pretty rare. I think fish in the water, right? right? So just start, and this is mostly, I will say, straight up, the work that we do is mostly geared towards white people. Not that people of color can't get things out of, recognizing our bias and making human connections and better outcomes, but this is really geared towards my colleagues. Understanding that we're aversive racists, and understanding, and I try to catch myself, I want to make it about something else. I don't want it to be about this, because that's upsetting. We don't like to feel bad. I want to make it about insurance. I want to make it about language. I want to make it about something else. Right? I catch myself doing that all the time. And trying to be in the moment. Right? I've always felt uncomfortable with people different than me. That's because I'm a human being. It is easier for me to relationship build with that white upper middle class family. I can shoot the breeze about the Final Four and where you go to college and this and that and the other thing. Trust build seconds. Right?
Yeah.
I should be able to trust build with a 17-year-old single black mom from North Minneapolis with a 2-week-old baby with sickle cell disease on her lap also. And if I'm honest with myself, is that as easy? No, it is not. Is it important? It's more important. So I've always had this discomfort. And this transcends race. If I'm with a family who doesn't speak English or whatever it is, I'm different, right? And I never knew what it was. This discomfort would come, but I knew I didn't like it, so appointment's over. So now when I start to feel uncomfortable, I know what it is. We can never get rid of our implicit bias. So if you get someone comes to your organization, we're going to remove everybody's implicit bias. Run for the hills. That is not a thing. That is not a thing. But what we can do is recognize when they're at play. And then you can make a conscious decision. Where do I go from here? My implicit bias happens every single day in the clinic. I'm better at recognizing it. Ray is excellent at pointing it out to us when we're not self-aware. And I so appreciate that. I never knew what it was, but now I know what it is. And that's when I know, oh, okay, sit back down. I gotta pull that chair closer to the mom. I need to look her in the eye. I need to ask her one more time, I'm sorry, how do you pronounce your baby's name?
Yes.
Right, that's when I know I have to, that's when I know I have to do the work, right? And instead of leaning away from that moment, and I still catch myself doing it, because I've got 4 rooms full, and I got artist charting to do, and I gotta quick this up, right? But instead of leaning away from that moment, I try to lean into it. And the last thing I'll say is this idea of a health equity timeout. I have been on the Minnesota Medical Association Health Equity Task Force for 3 years now, and Lynn Hassan Jones, who's an African-American woman radiologist at Mayo, coined this term, health equity timeout. Like if you have a procedure in this country, there's a timeout. There's an actual physical, everybody stops what they're doing. So we can focus, be in the moment. What's the patient's name? Check their armband. What's their blood type? Any allergies? What procedure are we doing? We're doing a knee replacement. Okay, which knee? The left one or the right one? This is about being in the moment to not make mistakes. And that's what I try to do, and I try to get my colleagues, this is not going to add an hour to your day. Just take a few seconds before I go in the patient's room to try not to think about all the other stuff, but then to acknowledge, how am I different than the patient I'm about to see? And that may transcend race, maybe other power things. And to be aware of that before I go in, and to prepare myself when it's not the white, upper middle class white family from Edina, that I'm going to start to feel uncomfortable, and to prepare for it, and hopefully, act accordingly. So, the last slide is Martin Luther King said it better than anybody. But I also like to include, especially for my white colleagues, because this is often new to them, and it was new to me, certainly 10 years ago, what James Baldwin said, because what I don't want to have happen is that my colleagues just feel paralyzed, right? This is overwhelming. What can I possibly do as a single person, right? The snowflake and the avalanche. What can I possibly do? You can make a donation to the Sickle Cell Foundation of Minnesota and the SCDAA. Yes, do that. Absolutely do that. And there's other things that you can do. This is hopeful work. And I will end with, we can talk about this for hours, but I love what Beverly Tatum said in Why Do All the Black Kids Sit Together in the Cafeteria? I don't know if you all read that book. it's fantastic. When I hear things like what my dad said or some colleagues that I didn't know in studies, she describes racism like smog in the air. Sometimes it's so thick you can see it. An example would be Charlottesville last year, or the church in Charleston. But sometimes it's not, but we're always breathing it in. And just because we didn't cause the pollution doesn't mean that we all don't have responsibility for cleaning it up. So thank you for your attention. I really appreciate it.
Isn't that awesome?
Drop the mic. Do we have time to talk? I mean, I can
Thank you so much.
At first, I will just thank you for being honest.
Yes.
And for being real, because that is actually the major first step. And you and I talked last night about this.
That was one of my first questions when you said you lived in racism. I mean, we lived in Wisconsin. I said, how was the racism? That was my first question. Yeah.
But I just want to honestly thank you for being honest and being real about this, because I remember I went to see an Indian doctor about, she was a dermatologist, and I remember to this day, it was 10 years ago, she never got close to me. And I was like, well, how are you going to tell me what's going on with my face when you wouldn't even get that close to me? She wouldn't touch me. She stayed over here and talked to me. So these are the medications you're going to need to use. But I never went back to her. Because it is about trust, and it is about building rapport and relationship with people. One of the questions I had for you when I looked at your tools was, what about when your colleagues say or do something? How do you
empower?
Deal with that?
This is a huge issue. For me, it's easier because I'm a physician, and I was the chief of staff at the hospital. I was on the board of the hospital for 4 years, right? But then I think about what I try to empower. So you're a nurse, right? That culture of medicine, that hierarchy. Or you're a fourth-year medical student, or you're, a nurse's aide, and you see the neurosurgeon do something racist. How are you empowered to say something without fear of reprisal, losing your job, getting a bad grade if you're the medical students, or that's one of the unique things I think and barriers to this work within healthcare, with that sort of culture of medicine. What Children's has done. We've just started a pilot. We've always had, everybody can get behind quality and safety. Even the white man sitting around the boardroom, we can all get around quality and safety initiatives. I would say an equity climate is a quality climate. We can factor that in. So Children's has always had SLRs, a safety learning report. You can go online if there's like a near miss or a medication error. Now we are piloting a system, an ELR, an equity learning report. So maybe you don't feel empowered to call out the powerful doctor on rounds, but you will have a way to have that voice heard. And we're evolving, and feel free, David, to chime in with our health equity team, and Children's is gearing up. But that is one way we're trying to give voice to everyone. So what I do personally, and what I counsel people to do, and it's either with a colleague or a family member, if you're white, right, you have to do a lot of ego massage, especially with physicians. You're so smart, you're great, and you're such a great doctor. Or with my dad, Dad, I love you. Thank you for working in the shipyard for 40 years, for sending me and Tim to college. And, not but and. Say and. Physicians love their data, right? And here's the data. When I showed that information about Children's to my kid's pediatrician, he started to cry. Right? How can this be? So I try to get to the core of why did you become a nurse? Why did you become a physician? Try to get to that human, and 99 times out of 100, it comes from this noble place. Quality. You say, and what does quality mean? Safe, timely, effective, efficient, equitable, and patient-centered. But you show the data, we're not doing that. Right? But you have to do a lot of preamble. You work so hard to be a doctor. And so I'm validating, and not to say but say, and this is what's happening. And I know you want the best outcomes for all of your patients. And that idea of don't confuse racism with the presence of bad people. Try to not make it, get it to the 30,000-foot level. This isn't personal, that you are a bad person. These are systems. We didn't ask to be born into this highly racialized society, but yet here we are. Right? That was a really long answer to your question. Sometimes it depends on who it is. So if it's at the personal level, just like what is your core? Organizationally, what I do with children's is I show a slide with a vision of the hospital. We are to be every family's essential partner in raising healthier children. Says every. Doesn't say families with insurance, doesn't say families who speak English, doesn't say Christian families, doesn't say US citizens, it doesn't say white families, it says every. So then you have a crossroads. You either change the mission and vision of your hospital, and then I will quit, right? Or you do something about it. So it kind of depends on who it is. If it's someone who's not empowered, we have this other way to do it. And I encourage you to find allies. Find someone who does feel empowered. Okay. So, yes, Rachel.
Yes, I just wanted to say that you are a doctor, and this is hard work that you're doing. And I think that if every white person in the world could do what you're doing, we're not looking for perfection. Like you said, you can't fix implicit bias. That's not what we're expecting. We're looking for just to stand here and say, up until this year, you're not afraid to say it. You don't feel like it's an attack, that, it's your fault, but you're acknowledging it, I think, is all of the battle, really. And so I just want to say thank you. That I know it's not easy, but that you are honest, and that you're honest enough to say, I'm still working on it. Because you're showing us your human side as well. None of us are perfect. You're showing us your human side, so therefore we feel like we can build that relationship better. And I do have a question, a common sense question.
Yeah.
When we come in every month for our transfusions, I do my hair. I'd rather just put a hat on because we're gonna be there all day. I don't, we have 3 kids, but I do my hair for that reason. And I know you all, right? But it's still like, do I put on a hat?
It's so deep.
If I do my hair, then I feel like I'm gonna be, and even though I know you all, but it's still there, like I do my hair every time I come to the clinic, right? So, and my question is, when you talked about knocking down the doors, you talked about HIV, so certain groups have power to knock down the doors. What would you say? I mean, there's so many issues with sickle cell. If you could say even 2 or 3 doors that are the most important that you think for this community to knock down, what would those doors be?
I think the one that could have the most immediate impact would be, and this becomes a political conversation, but to think that medicine is not political, I think that's part of the barrier, that we like to think we function in a bubble in healthcare, that we're somehow unaffected by things. If I think about politics as policy, not as Democrat Republican, policy would be universal healthcare. It is shameful that in this country we don't have healthcare for everyone. It is shameful that we don't have healthcare for everyone. There's Physicians for a National Health Plan, there's a Minnesota chapter, there's a move towards, you can lobby for that and vote for people who will support healthcare for everyone. It's appalling to me. It is so bad that we now just hired a second full-time employee that all she does is fight with insurance companies to get prior authorization for medication. We have 2 full-time employees. That's all we do. We're trying to send a patient home and they get there with their prescriptions. Oh, it's not covered by your insurance. It's unbelievable. And that was a long answer to your question, Rachel. But I think, so sickle cell specifically, that would help, I think, a lot specifically, because many of our, unfortunately, the majority of sickle cell patients in the United States, you may have better data than I do, have state Medicaid or Medicare or nothing. So that would be something that, yes, it would help all Americans for sure. But definitely would help patients with sickle cell disease as well. And I think continue to support things like SCEcoalition.org, the American Society of Hematology. I think what Yvonne talked about, these like fast tracking, like what are we waiting for? And I think we're seeing some benefits of that. And I think I might let Beverly help answer that question. What do you think would be the best thing for the community to do?
Example, I know that we're trying to advocate for adult
Transition, that would be
care.
Yeah.
So, and I know it's very political. What are the legislative doors that we need to knock down for something like that?
So I would say the Minnesota Department of Health. So we have newborn screening that is mandated by the state of Minnesota. So in my mind, the state of Minnesota is responsible for the outcomes for that patient. It shouldn't end when they're 2 weeks old and they get confirmation that they've seen me and Kristen and they just take it off their list. Because they also have, the state has long-term follow-up programs for many other diagnoses throughout a lifespan that the state of Minnesota is not supporting, right? So in my opinion, the state of Minnesota should be supporting the University of Minnesota in developing a comprehensive sickle cell center for adults. So thank you. That's something you could do right now. Your state representative and your state senator and calling the NDH and the health commissioner. Like, why do we not, life expectancy is actually decreasing in sickle cell disease. And some of that is patients are living longer and having more cumulative effects, but some of that is, the peak time to die is between 18 and 25-ish, right, that transition. So we're doing great in pediatrics, right? Almost all of our patients will make it to adulthood, right? So that's great. So we have this flood of young adults. Where do they go? Where do they go for their care? So, yeah, that's something we can do. I better stop talking.
Thank you. I appreciate that. And first and foremost, I just want to honor anyone that needs to leave. I totally understand it. This is the very last presentation, and it's the last, but it's not the least. It's actually quite important about finding medical homes for our young adults and adults living with sickle cell disease. And so, particularly if you are a young adult or the parent of a young adult or a provider in the room, for many years we focused on finding hematologists, and I never want to leave the impression that our patients do not need a hematologist. They absolutely do. That is their blood specialist. But in the pediatric world, they love on you like your pediatrician. And that is not what the hematologists do in the adult world. And I am intentional. It's not good. It's not better. It's not worse. It's different. Now, are there things that could be better on both sides? But it's different. And so what's important is how do we navigate those systems to get to the better outcomes. So I'm going to have our last speaker come up, the highly esteemed